So thank you all for having me here. So Rajiv is not. So managed to fool Rajiv into thinking that I'm an expert on genetics. So managed to invade myself into this. So let's talk about genetic testing as a pre-transplant worker. So first of all, yes, just a few things baseline. I think we have already covered this in most of our discussions, so I'll be very brief with this. So why do you want to do a genetic test before transplant? The first thing is, of course, to identify the cause of CKD. That will help you in many ways because you know whether it can recur after transplant, you know the prognosis of the disease, and you also can identify, as I said, they want to select a living donor for transplant because they must not be having the same gene mutation. You can provide genetic counseling to the patient if they have a genetic disease, and you can predict the risk of recurrence in the transplant kidney. And lastly, pharmacogenomics, that also will help. We are not going to talk about that. So what are the risks? So the other side is there also. When you identify VUS, what you do, then it becomes uncertain. And you know, we have a lot of problems in VUS. We've been discussing that whole day and not reached the point about it. Then the need for additional testing and costs, because you are going to test the patient, then you have to test the donor, maybe somebody else. So these costs will all multiply. Already they are spending a lot of money for the transplant. This is going to be a problem. And the stress. So if you have suppose somebody else, the family is having the disease now, maybe they will be asymptomatic now. You tell them you have a genetic disorder. That's going to cause more stress and problems. So all these problems will come into play. You have to have a proper counseling before and after to avoid too much of stress. Insurance discrimination is still a possibility in our country. We don't have laws for this as far as I'm aware right now. And lastly, what may happen is that you may develop a gene, you may have a gene in the donor which may prevent a live donation, even if you know that the risk of donation is less. This may prevent it. So that's one of the problems. So there are risks involved in doing a genetic test. It's not an easy session, but still in many places we are forced to do it. So where do we do the test? So these are the conditions in which we do it. Mostly in people under age of 50 years, not more than 50 years, usually we don't do a genetic test. But in those patients who have primary FSGS, probably genetic FSGS, steroid resistant, complement-mediated kidney disease, that's a very important segment because many of them will have recurrence if they have the abnormal mutations. And a family history of kidney disease, there you have to go strongly that this is genetic disorder, you have to do something about it. If the kidney disease etiology is unknown, sometimes you have to do, sometimes maybe you may feel that it's a chronic glomerulonephritis and probably may not require, but in many cases, if you have suspicion that it's one of the diseases like a complement mediated, then you may have to do a genetic test. The stone disease history is very dangerous because many of these stone diseases may have an underlying PH1 mutation. So that is a place where I would suggest you do a genetic test in all these patients. Cystic kidney disease is very important to identify the donor, so you may need to do a. But suppose it's a spousal donor, maybe you can get away without a genetic test. You can go ahead and transplant even without a genetic test. I know congenital kidney disease is external manifestation. That's a standard tool. And if there is consanguinity, one of the recommendations is of consanguinity. If there is kidney disease, you should do it. I'm not really sure that really is a good, unless you feel that that's a strong genetic disease, consanguinity itself should not you do a test. That's my personal opinion, even though that is one of the criteria for doing a test before transplant. So these are the various situations in which you do it. And then the donor. So the next thing is donor. There have been some guidelines as to which patients should, which donor, live donor should undergo genetic testing. The first thing is a donor with a family history of no genetic disease in one first degree relative. So if they have a genetic disease in one first degree relative, then you should be doing a genetic test before they donate a kidney. Then if they have a family history of suspected disease, even if it is not a genetic disease, a suspected kidney disease, even then you should be able to test them for a genetic disorder. Then they have family history of disease of unknown etiology in this. So that's the next level. So either you have a definitely proven genetic disease or a suspected genetic disease or a disease is likely to be genetic. So these are situations where you can test a donor. And lastly, if it is an X-linked disease, even a one secondary relative may be enough because many of these X-linked diseases may skip a generation. You may miss it in that particular generation, you may get somebody else, like Fabry's disease, something like that. So it can happen. We're going to talk on Fabry's, so that time we'll talk more. But this is the standard guidelines for testing donors. Of course, if the recipient has a disease and it's a related donor, you should be testing in that situation. So what test will you do? Again, this we have already discussed, I am not going to that. You have the options, you have whole exome sequencing, you have targeted panel sequencing, you can do a CMA or a MLPA, all depending on different situations. So let us discuss a few cases because that is where it gets interesting. So this is a 19-year-old girl who presented with anemia, worsening renal function, proteinuria, microhematuria, following treatment for infertility with hormones. So she also had thrombocytopenia, and then she developed hypertension and started worsening creatinine. That's the time when she came to us. Peripheral signature to lymphocytocytes, LDH was more than 1000, and she had no anti-CFH antibodies. So she was started on plasmapheresis. And then after 6 sessions of blood, she improved, everything got corrected, renal function became normal, LDH and hemolysis reverted. Followed 2 months, she was absolutely alright, then she developed COVID. Now, COVID is one of the things that precipitates TMA, where TMA is present. And this patient developed a severe TMA. She had seizures, hypertension, lymphocytosis, rapidly worsening renal failure, and she required ventilator support. Then she multiple sessions of Plex, but she took 2 or 3 weeks to even come out of the ventilator. And finally, when she recovered, her kidneys were gone completely. And she had severe hypertension and multiple antihypertensives, but we had to do intensive ultrafiltration, get all the fluid out of the body to control the peak. Subsequently, hemolysis and platelets are improved, but she continued to be on dialysis-dependent renal failure, which she never came out of. So we did a genetic study, and this genetic study is a NGS whole exome sequencing, and it showed a CFHR1 mutation and another, both in exon 6, you can see 2 mutations, but both are reported as VUS. So that's a problem now. So what do you do with this? So with this report, can we go ahead and kidney transplant? The risk of recurrence, or should we take this because it's a VUS. So VUS, you cannot take a diagnostic decision based on a VUS. So you cannot take this. So these are the questions which were asked. But the problem here is that a complement mediated disorder is a condition where there is very commonly deletions and duplications. So we should not be happy with just a NGS panel whole exome sequencing. We should do a subsequent study. So we did the MLPA. And now you see that you have a heterozygous duplication of the CFH gene. So CFH gene changes the scene completely because now the CFH gene, there is chance of recurrence of the graft is almost 80 to 90%. So you don't have an option for this girl. You cannot do a kidney transplant alone based on this. So that's the importance of this case is that.
So there is one deletion and one duplication.
Yeah, one deletion.
So the probe ratio, something around 1.5 is a duplication, and something around 0.5 is a deletion. So here the deletion in exon 1. So there are 2 different genes.
There are 2 different genes. That other one. This is the important. Actually,
the first one is a dominant.
Yeah.
First one is a dominant variant, so it makes sense.
Because even dominant CFH genes, they can cause problems. But CFHR4 actually, if it was there, I would not have bothered. Because those really don't cause much issues in transplant. Even though it's reported as pathogenic, usually the pathogenicity of all these CFHR is by producing anti-CFH antibodies. So we have this, I'll come to that later on in other cases. How it happens.
What is the MLPA probe ratio?
So that is, it should be 1, right? Ratio will, it's the
So it is the ratio of the number of probes which are
not the number but the height of the peak height. So the peak height is larger. So 1.5 times larger than the baseline. So baseline is done with some normalization. It should be 1 because if there is 2 copies. If it is 1.5 more than 1.36, then there are 3 copies. If it is 0.5, then there is 1 copy instead of 2.
So it's all because it's all, if there one gene, it will rise 1 building.
So
if there are 2 genes, it will be double size. There is no gene, it will be half the
So
size.
sometimes it will be double size or it will be 2 peaks.
Yeah.
That also comes.
No, 2 peaks doesn't come here. It is only because this is the area. It's that region only for which probe set is
for
there.
idiots like us, so more the peak, more the
Height, more height is the peak, there is a duplication.
Duplication. Less height.
Less height is
more is bad. Both
I
are
don't
bad.
know. Both are bad. Application is also bad.
It
Deletion
has
is
to
also
be
bad.
I think for us, we just read the report. No, that's enough. Heterozygous duplication CFH test.
R1, then he could have been an additional.
But the problem with CFHR is there is a lot of variation in population. The problem with CFHR is there is a lot of deletion duplication which exists in
It's a normal population.
the normal population.
So
Go ahead.
how did they interpret? How did they interpret?
So based on this, what we found, pathogenic CFH mutations have high risk of recurrence, and most of these are large deletions and duplications. So that's why I said that we must do a test for CNVs when we are doing complement gene assay and interpretation in the clinical picture. This girl has definitely a very severe complement disorder. She does not have an anti-CFH antibody, so we are suspecting a major gene abnormality. So that's why we have to look for that because this is going to recur in the graft kidney. So based on this, now there are only two options for it. We have to either give a lifelong eculizumab and do a transplant, or we have to do combined liver kidney transplant. So we listed her for liver kidney. She's been waiting for the last 1 year. She has not received so far. She's on dialysis, but in between she developed a severe episode of when she developed fluid overload, hypertension, insulopathy, small bleeds in the brain. But she came out of that also. She's now still waiting for a liver kidney transplant. The second case, this 42-year-old male with end-stage renal disease, and the ultrasound showed a hyperechoic medulla suggestive of medullary nephrocalcinosis. He was planning for transplant, but in view of nephrocalcinosis, oxalosis was suspected and a genetic study was done. Now, see, genetic study, it showed two variants. One is this KCNJ1 mutation, which is a homozygous mutation, and that is reported as uncertain significance, class 3. Whereas they have another HOGA1 mutation. Now KCNG1 is actually a ROMK channel in the thick ascending limb. So it can cause distal RTA and therefore it can produce the phenotype can be produced right. It explains the phenotype very well even though it's in the US. HOGA1 is also present. Now HOGA1 is also reported as likely pathogenic, which present heterozygous state. And it, of course, HOGA1 is for PH3 mutation. So now what do you do? So the question asked to me was whether this patient can go at the transplant or she'll have oxalosis in the kidney. But what is clear here is that we have mutation of HOGA gene, which causes, definitely there's pathogenic mutation, but it's present only in the heterozygous form, whereas there's an autosomal recessive disease. So if you want to say that's a pathogenic, it should be present in homozygous form. So we can safely ignore the HOGA mutation in this patient. Whereas the KCNG1 actually explains the entire phenotype. Unfortunately, we use. So we can't really be sure, probably we might. But anyway, I'm not interested further because it is not going to recur in the graft kidney anyway. So the new kidney does not have the gene. So probably the advice to go ahead with the transplant, and they have transplanted this patient and that patient is doing well after transplant. No recurrence so far. I think it's about 6 months down the lane. That's the. So again, that's what I said. So HOGA mutation, heterozygous, so we can probably ignore it. So learning points is that genetic report is another laboratory test. Interpretation depends on the clinical state. So you must always interpret the clinical context. And you have these genes which helps you to assess the risk of recurrence. So HOGA, if it was actually homozygous, you should not be doing a transplant here because when recurrence, probably you should have access to nedosiran or something like that, which is now available. Or you can do a liver kidney transplant, that will be a treatment of choice. Anyway, this patient does not require that. So it shows problems interpreting the US, but in this case, fortunately, it was not important for us, so it really doesn't matter. So it's the third girl, another complement mediated. She was a case of HUS treated elsewhere. She had severe renal failure. She had anti-CFH antibody positive. So when she came to us, her grade was already 6 or 7, and then by the time she had not been on Plex so far, but we started on Plex, but she did not recover renal function, and she was planned for transplant from her father daughter. She is asymptomatic, on peritoneal dialysis, no features of HUS. That was the presentation for us. And so what we did is pre-transplant, NGS did not show any mutation, so again we did an MLPA, and again here it showed a homozygous deletion in CFHR1, and that is shown to be pathogenic. So susceptibly allele is what they have said. So it's likely pathogenic. Homozygous.
None is present, so it is
It's completely zero.
So if I allowed, I can show some slides on
Yes. I think in your presentation you can do that. A lot of happens. So what to do now? This patient has got a homozygous deletion of CFHR1. So the options are to plan for a combined liver kidney transplant, ignore this and go for a kidney alone transplant, check for a negative genetic test in related donors. So if you have a related donor, check for a genetic test, or you just don't do the transplant, just continue on dialysis. Again, like I said earlier, so CFHR1 mutations are very rarely associated with clinical disease. If you look at the genes, you see on the chromosome CFHR3, 1, 4, 2, this is the pattern. Now, one of the important things is that you will see a lot of CFHR3, CFHR1 mutations, deletion, duplication can occur. Both these are contiguous genes. So you can have a genetic mutation in this deletion, duplication can occur, and that is present in Indian population also up to 30 to 50% of people. In this crowd, probably some 5 of us, 10 of us may be having that mutation. So it is not associated with complementary disorders. And rarely, if they are homozygous mutations, they can present anti-CFH antibodies. Heterozygous mutations, even that is not present. So if you have a homozygous CFHR with CFHR1, you can develop HUS by an antibody. Now this girl had a homozygous CFHR1 mutation, probably that is what caused the antibody in it. Maybe there is some amount of CFHR3 also involved because it is a CFHR3 CFHR1 deletion, combined deletion which causes these antibodies. So we anyway proceeded the transplant with the father as donor, and both are doing well. 3 years after transplant, the creatinine is normal. So point I made here is sometimes genetic tests can confuse you. So we put you in a dilemma whether we should do a transplant for this patient or not. So you should seek the advice of genetic experts and probably experts in complement also in this case. So this is another interesting case where there are several mistakes which occurred. The 35-year-old lady with ADPKD, she had very thin frame, weighed around 40 kilos, but had huge kidneys. Abdomen was really distant. Father died of kidney disease, so we don't have any data about the father. Now her creatinine was about 7. She is planning for a preemptive transplant. Mother is a suitable donor, asymptomatic, normal blood pressure. All the usual evaluation was unremarkable. But then we did the CT angiogram. Ultrasound did not show any cysts. CT angiogram showed, actually you can see 2 cysts in the liver here and 3 cysts in the kidneys. 1, 2 and 3. So liver and kidney, so many cysts, 50 years of age. Now there comes a problem because she has got liver and kidney cysts. Mother. The father had ADPKD, probably died of it because he had died of kidney disease. We do not know. Mother is completely asymptomatic. Everything is normal. Even the ultrasound was normal. But CT showed these cysts.
And why was CT done?
There is routine angiogram, CT angiogram for the transplant worker. It's not done for this thing.
More people think more cysts will come. If you do MRI,
More cysts will come.
people say unless it is 10 or above, you don't.
Yeah.
So that's the problem.
So now we have a problem, so what to do? So we did the genetic study of the mother. So that's mistake number 1. But anyway, we did the genetic study of the mother and that showed a GADAP mutation, likely pathogenic. So autosomal dominant heterozygous person, so it is a deletion of at this point. Then she also had a PKD1 mutation, which was shown to be of uncertain significance. Now this mutation is in mind. How can you take this mother? It's a problem. So actually we did her mother's brother was also the donor. He had the same GADAP mutation. We didn't do anything for him. We first did a mutation analysis and he was found to have the same mutation. So we rejected him also as a donor. Now there is no donor. Only husband was the donor. But one of the problems husband is asking is, they had a daughter who was 8 years of age and she had abdominal pain and ultrasound was only showed bialysis. So daughter's having a mutation. So he asked me later on if she requires a kidney, who will give? So he was wondering whether to give to his wife or give to his daughter. So these are my so I have no answer to that. So we sat on ice. And then, so what is the problem here is that the related daughter of the family has a high likelihood of same genetic disease as the recipient and small signs may be the clue. So what we do not know, the patient may be having a compound heterozygous mutation from father and mother. That's what I thought may be the reason. But here the basic mistake, fundamental flaw here is that you should first do the genetic evaluation in the patient in the initial proband. Otherwise you are going to land with other stages. So these are all early days. We are just flying off the cuff. So this is what happened. So what we did is finally we did the genetic study of the patient. So actually I asked a question also. Supposing this patient had come to you, this lady had come to you and with cis as a donor for somebody else, not for ADPKD, would you have done a genetic study? You would not have done it, you would have taken that lady as a donor. It should have been, you would not have done it, just taken her as a donor. Because small cis will just ignore in adults, especially 55 or 54-year-old adults. So this lady, she had two mutations in PKD1. Now this particular uncertain was same mutation as present in the mother. And this Gennard mutation also the same mutation as present in the mother. But this mutation, which is likely pathogenic, that was probably the pathogenic mutation here. So probably not the others. But we are still a problem because the same mutation is there in both the mother and the thing. So we do not know if it has contributed to the pathogenicity. This is another component. I don't know whether this is in cis or in trans. Not sure, but still.
See, this is in trans, exam 15, exam 10 in trans.
Okay.
These two genes, so this is called a double heterozygous. So two different genes having heterozygous mutation. So we, so
Digenic.
this is double heterozygous. So you cannot call it digenic if you are not proven it. Rather, Bardet-Biedl syndrome is the classical example of a digenic where two celiopathic genes can work together. So this, you cannot tell that this is digenic. So we really have to find out how much this likely pathogenic message must have been reported and what is the manifestation of polycystic kidney disease.
So the Gennard mutation.
80 years after old presentation and she has nothing. So I don't know.
Because Gennard classically has a very mild phenotype of ADPKD. It is not a very severe phenotype of ADPKD. So the thing is, now we are not sure because this lady has a severe phenotype. She has rich NCS by the age of 35.
That is due to that exam 15.
Yeah. So in order to confirm that, we did the mutation study in the daughter, that is the child, 8-year-old child. She also has got probably a severe mutation because she has got multiple cysts and she's only 8 years of age. So this is going to progress. So that daughter also had the same mutation, this exon 15 mutation. She did not have any of the other mutations. So based on that, we concluded that probably this exon 15 C4853, that is probably the significant mutation. It's a truncating mutation and it is severe phenotype, and that is what is causing the disease in both the mother and the daughter because both are presenting with a similar phenotype. And probably the grandmother, that is the original person was planned as a daughter, is probably having a very mild phenotype.
Yes.
So based on this,
So
we went ahead with the transplant.
yeah, that is the best thing to be done.
Yeah. So for 6 months actually after the transplant, we sat on it for more than 1 year because we didn't know what to do. Then finally we decided.
So see, even a truncating mutation, deletion, termination, even if it gets BS1, very severe, it is a mild disease.
Yeah. And over this last 6 months, we repeated ultrasound for the daughter and there are no increase in number. Ultrasound is not showing any cysts now, still. So the daughters. So final conclusion is that the recipient and doctor share a pathogenic phenotype in exon 15 and the daughter and mother share a common pathogenic mutation in Gennard exon 9, which is probably not a very significant mutation. But in the granddaughter is only one mutation. So the gene response severe features a truncating mutation PKD1 exon 15. So that is our conclusion. So based on that, we decided that this Gennard mutation can be safely ignored and we entered the transplant. So this last case is more of a lingering problem rather than a case as such. So this 20-year-old gentleman presenting advanced CKD hypertension, no other clinical signs, contradicted his ultrasound. He was planned for transplant from mother-daughter. Mother had microscopic hematuria with dysmorphic heart disease. Therefore, we didn't accept as donor. And this, when we evaluated this, he did not have, because he came with advanced disease, we did not know what it is, but he had auditory hearing loss when tested with audiometry. Clinically, he has no hearing loss. So, probably we thought it was a Alport phenotype. Now, this was somewhere in 2010. We did not have access to genetic testing and all that. So, we did a transplant for the father. That was from 2011. So now at this point of time, his brother came with hematuria and urticaria. That is the brother of the transplant recipient. He is now 28 years of age, younger brother. And so we did the mutation, and then we found he has a called 4A mutation, heterozygous, so that is some likely pathogenic mutation. And another called for A3 mutation. So A4 and A3, both mutations, but this is a US, uncertain significance. So anyway, he has got a definite mutation for Alport syndrome. This is very clear cut mutation. So probably this is the same mutation present in the brother. We didn't test it. But the point I wanted to make is that his mother continues to have microhematuria, normal renal function, no proteinuria, but father now has a creatinine of 1.5 with hypertension. It's now 10 years after donation. His creatinine started increasing. So his continuous follow-up and remain stable. So probably should we have done testing of those days for the father and mother? That's the problem. We don't know what the father has. Whether he's got the US or whether he's got the cold form mutation, we don't know. So that is the problem. It's because we don't do a genetic test, we don't know it. Probably today we would have done.
How old is the father now?
That's what he has got. He's otherwise okay.
How old is he?
He is now, I think, 50s, late 50s. Mid 50s. I think he was only 45, 46 when he gave the kidney. So.
Is that design?
No consign.
And father doesn't have at the moment in hematuria or
No hematuria. He's got hypertension and he has got this thing. So that may be just related to the donation itself. We can't be sure. So to conclude, genetic testing is an important part of the transplant workup. So we should do in unknown CKD, familial CKD, cystic kidney disease, renal stones with CKD, and donor evaluation is also very important, as important as seeing the recipient. So genetic test will help to diagnose, prognosticate, and assess chance of recurrence of disease after transplant, and also to select donors. The new science of pharmacogenomics, we already discussed a lot about that, which is also part of the genetic analysis. Now the problem is that results are, the risks are that the uncertain results sometimes will confuse, cost may be a problem, and sometimes the wrong decisions may be made due to inadequate data and poor understanding of the implications. So that's important. You should always discuss with a person who knows, who is a geneticist, and take decisions, because that's very important. And another reason is properly counsel the patients before and after. Thank you.